Good day and welcome to this session. We'll be discussing drug use in pregnancy. And I am Ajiboye Akinyosoye. I'm a consultant obstetrician gynecologist with Obafemi Awolowo University Teaching Hospital Complex. So the learning objectives for this course, at the end of this course, we expected to know the prevalence of drug use. We understand the context in which we are talking about drug use, the classes of drugs that are used in pregnancy. We are going to review the pharmacokinetics, and we expect all you to know the effect of drugs on the developing fetus, and also we expect you to have a working knowledge of substance abuse in pregnancy, and finally how to approach drug prescription for pregnant women. So we're introduced by saying that drugs have been a source of drug use in pregnancy has always been a source of concern for healthcare practitioners and the pregnant women involved. And it's because the drugs can predispose the fetus to developing to teratogenicity, where fetal malformations occur. Apart from the teratogenic effects, we could also have problems with the developing fetus, such as spontaneous miscarriage can occur, intrauterine growth restriction, and preterm births. And then there could be long-term consequences for the baby after birth, such as psychomotor problems, behavioral and intellectual concerns. And also, there's also a risk for cancer formation in some with some drugs later in life. So, pregnancy, as you know, is a phase with many symptoms, which are actually physiologic, but has become medicalized in the sense that so many of these symptoms tend to be looked at as problems which will require one medication or another. There is tendency to provide drugs for every symptom a woman presents with, in spite of the risk. And in another context, the use of alcohol, cigarettes, smoking, and the intake of herbal concoctions and other medicinal plants by some women also constitute drug use in pregnancy. And these also have their own effects on that pregnancy and the mother and the developing fetus. In a multinational World Health Organization study that was carried out, it was revealed that about 86% of pregnant women took drugs while pregnant, and they took an average of 2 to 3 drugs during pregnancy. A study done in Ilorin by Aboyeji et al. Revealed that over 80% of women attending the antenatal clinic were found to have been taking at least 2 or more medications during pregnancy. And this finding has been replicated all over the world by several other studies. Well, it's reassuring to know that in spite of this heavy use of drugs by pregnant women, teratogenicity actually accounts for only 2 to 3% of the whole population of the occurrence of teratogenic effects in pregnancy. Also, we need to understand what happened in the past. Not in the 1960s, it was discovered that about 30% of pregnant women who were exposed to thalidomide developed, the babies developed phocomelia, and this led to a ban on the use of that medication. Not until in recent years, where use for thalidomide was found again in selected conditions, it remained banned for almost 40 years. Some studies reveal that substance abuse accounts for up to 25%, are found in up to 25% of pregnant women. And these are all part of the concerns for drug use in pregnancy. The medications that are used in pregnancy can be loosely classified into routine drugs, prescription-only drugs, over-the-counter drugs, herbal medications, and psychotropic drugs. Under the psychotropic drugs, we have anti-epileptic drugs, we have the drugs antidepressants, we even have the drugs that are used socially and the illicit drugs. So I categorize them all under psychotropic drugs. We'll break them down as the presentation proceeds. In our own setting, low resource settings such as Nigeria, we have substances like over-the-counter drugs being abused regularly, such as acetaminophen, aspirin, chlorpheniramine, the commonly called Piriton. They are all abused by so many pregnant women without any clear-cut medical indication for it. We also have a heavy tendency in this environment for people to use a lot of herbal concoctions, and this is used in and out of pregnancy. So many women get pregnant while on these medications. In high resource settings, we have the abuse of alcohol, use of marijuana, crack, cocaine, methamphetamines, opiates are all abused by varying classes of women in the high resource setting. So this is the context that we're talking about for drug use in pregnancy. The pharmacokinetics of drug use in pregnancy. We must understand that as there are physiologic changes in pregnancy affects the metabolism of every woman. Drug metabolism, pharmacokinetics are also affected in pregnancy, and in this case, we find out that the bioavailability of some drugs or most drugs are lowered. The absorption, the circulation, the concentration of drugs in the circulation are also lowered. And this is because there is increased protein binding, there are larger plasma volume for the drugs to circulate in, and then there is increased excretion of these drugs, amongst other factors. These are the general factors that affect the pharmacokinetics of drug use in pregnancy. Also, conversely, however, the parenteral absorption of medications in pregnancy is generally more rapid because there's increased blood flow to for example, if an intramuscular injection is given, there's increased rate of absorption because there's increased blood flow, and as such, the drugs are more rapidly absorbed. Then alteration of hepatic enzymatic activity can lead to increase in drug accumulation or decrease the elimination of some drugs. This leads to the rapid onset of action of some drugs and prolonged duration of action in some cases. Also, we find out that volatile gases are more taken up easily, and then there's the onset of action is decreased. That means the volatile gases that are used in anesthesia, for example, the onset of action is faster than drugs than when the woman is not pregnant. So the summary of the pharmacodynamics is that there's increased sensitivity to volatile anesthetic agents. There's increased sensitivity also to intravenous anesthetic agents. There is a decreased sensitivity to some local anesthetic agents, increased sensitivity, I beg your pardon, also to local anesthetic agents. And then the changed therapeutic indices, also occur in many drugs or women who are pregnant. So also want to mention the summary because it will be difficult to go into detail of all of these changes. So we want just to pick the most important systems and mention the summary of the changes that occur. For example, in the gastrointestinal tract, there's reduced gastrointestinal motility. This is a general effect both on drugs and anything consumed orally. There is a reduced gastric emptying time. There's increased gastric emptying time. There's reduced gastric acid secretion in some cases, and in the lungs, you have increased tidal volume and hyperventilation. So these are part of the changes that occur in the system, in the body system, that affect drugs. In the circulatory system, we know that there's increased cardiac output, there's increased blood flow to the skin, there's peripheral vasodilatation also occurs, and this leads to increased parenteral absorption of medication. The increased blood flow to the kidney results in increased glomerular filtration rate and also increased reabsorption. So sometimes the increase in glomerular filtration rate may not necessarily lead to increased elimination, because some drugs are more rapidly reabsorbed. So that effect may counter the initial effect of the increased filtration. So in summary of all of this, we find out that many the effects pregnancy will have on a particular drug, for example drug A, is going to be different from the effect that pregnancy in that same woman will have on drug B. So many of these changes find themselves being counterbalanced in pregnancy depending on the agent that we are discussing. All right, so the adverse outcomes that occur when drugs are used, because the most important thing we are discussing in this topic is the adverse outcomes resulting from drug use in pregnancy. So we find out that the factors involved in the type of adverse outcome that occur or when it occurs depend on one, gestational age at the time of exposure. And on this we'll talk about this a little more after this particular slide. The dose of the medication used, the duration of use, the degree of the transplacental transfer, genetic predisposition, and environmental factors. For the gestational time, at the time of gestational age at the time of exposure, we look at there's a classic period, teratogenic period, and it's described as between the 31st day to the 71st day from the last menstrual period in a 28-day cycle. So if the pregnant woman is exposed to some drugs with high teratogenic potential at this time, the likelihood of developing a teratogenic effect is high when it falls within this range. But before 31 days, the exposure to the same teratogen may have an all or none effect. And what I mean by this is that if that particular teratogen is brought in contact with the pregnant woman before the 31st day of gestation in a normal 28-day cycle, the drug may actually not allow the conception to go on, or it may have no effect at all. So that's what we mean by the all or none effect. Is either there's total destruction of that pregnancy at that point in time, or it has no effect at all. Now, when this same person is exposed to these same drugs after 71 days, it may have no effect, or it may now lead to problems with the pregnancy, problems such as spontaneous miscarriages, intrauterine growth restriction, preterm birth, stillbirth, or even after birth, the baby can develop cognitive impairment, social or developmental functions. There may be metabolic problem may develop later in life. There may be late onset cancer, such as the clear cell cancer can occur in females, female borns of this who are exposed to some medications while pregnant. Okay, so these are the summary of what can occur when teratogens are exposed. When a woman is exposed to some teratogens at gestational ages between 31st and 71st days of pregnancy. Okay, so we also want to mention touch on the issue of the transplacental transfer of drugs. The ability of a drug to cross the placenta barrier depends on the size, and we should note that virtually all drugs cross the placenta with in some degree, except for large organic ions such as heparin and insulin, that don't cross the placenta, but most other drugs tend to cross the placenta. The other factors that come into play are the solubility, which might be lipid solubility or water solubility, and the extent of protein binding will all determine how much of a medication, how much of that particular drug will cross the placenta. And then we should know that as a rule, drugs with molecular weight of less than 500 grams per mole will diffuse freely across the placenta, and drugs with greater than 1,000 grams per mole do not cross the placenta, while those in between the 500 to 1,000 grams per mole range will cross with a varying degree. Of course, as the higher the molecular weight, the more difficult it is for the drug to cross the placenta barrier. Okay, so there is also increased blood flow or decreased placenta thickness, increased placenta surface area, are all factors that come into play in facilitating transplacental or inhibiting transplacental transfer of drugs in the later trimester, that's the second and the third trimesters. So from there we move on to the other effects that drugs can have on that conception. If there is no direct toxic effect or teratogenic effect, there are other effects that can occur, both to the mother and the fetus and that pregnancy also. Some of these effects include the constriction of the placenta vessels, impairing nutrient and gaseous exchange. This will lead to intrauterine growth restriction, or you can have hypertonia in some cases, leading to anoxic injury in the fetus, or to even alter the maternal physiology system. For example, some drugs can cause hypotension, some drugs can cause hypertension, some drugs may cause hyperglycemia or hypoglycemia or electrolyte dysfunction, as the case may be. So the effects that would occur depends on the drug we're talking about and at the gestational age of that pregnancy. And please note that as I'm using drugs, it's a general term for both the medications and the substances. So we are describing it in a general fashion. All right. So we move on to talk about the classes of drugs that are commonly used in pregnancy. We know that most pregnant women will take hematinics, which include the iron supplements, folic acid, vitamin C, and some other vitamins, maybe vitamin B complex, are all prescribed by healthcare workers and pharmacists, chemists for women in pregnancy. We also know that because, like I said initially, that most symptoms are medicalized. We have women taking a lot of antiemetics, antacids, analgesics, antimicrobial agents, and importantly too, vaccines are also prescribed while women are pregnant. There are women who take medications for chronic illnesses such as diabetes mellitus, and they could take drugs such as metformin. They could be on drugs like metformin. They could be on Daonil and co. Then hypertension, you could find women who have been on angiotensin receptor blockers or ACE inhibitors while pregnant, such as lisinopril, losartan, valsartan, methyldopa, and all the classes of antihypertensive medications. They could be on this pregnancy, on these drugs while pregnant, or be on the drugs even before they were pregnant. And we know that many of these drugs, if they are not properly prescribed, could have effects both on the mother and the fetus as well. To make drug use safe in pregnancy, the Food and Drug Administration in the United States of America in 1979 introduced a classification system for medications, and this is to adequately guide physicians whenever prescription is being considered for pregnant women. And this was classified into category A, B, C, D, and X drugs. However, by 2014, the classification system was being phased out by a new system, the PLLR system, which replaces that lettered classes with specific narratives addressing each drug in relation to the pregnancy, lactation, and the reproductive potential of the fetus. So while that is a new system not yet adopted by many countries, the FDA classification still proves to be very useful and relevant to physicians both in the United States and even in our own settings. And for the purpose of clarity, we'll just describe the various classes or categories of these drugs. So category A drugs are drugs that have been studied under adequate and well-controlled studies and have failed to demonstrate a risk to the fetus in the first trimester and also in the other trimesters. So that means those drugs have been studied, well studied, and there is actually no problem with them at all. Category A drugs. And there are the category B drugs where animal reproduction studies have failed to demonstrate a risk to the fetus, and there are no adequate and well-controlled studies in pregnant women. We must understand that studies are difficult to carry out in pregnant women. Such studies to determine the risk status of a drug are difficult to carry out in pregnant women. So you now find that animal studies may be the next available one for such drugs. All right, so we now have category C drugs, which are animal reproduction studies that have shown that there have been adverse effects on the fetus, but there are no adequate or well-controlled studies in humans. But potential benefits of using that drug may necessitate its use in pregnancy. In spite of there being an adverse effect in the fetuses of animals, the drugs are still used because the benefit of using that drug outweighs the risk. And then we have the category D drugs, where there's positive evidence of human fetal risk based on the adverse reaction data from investigational or marketing experience or studies in humans. But there's potential benefits may warrant the use. Its potential benefit may warrant the use in pregnancy despite the risk. And then you now have the category X drugs, which are drugs in which studies in humans or animals have demonstrated fetal abnormalities, and or there is positive evidence of human fetal risk based on adverse reaction data from investigational or marketing experience, and the risk involved in use of the drug in pregnant women clearly outweigh any potential benefits. So we can see that from this, there will be few drugs that will be in category A for use of pregnant women, while most drugs will fall under category B, C, and D for use, while category X drugs are, of course, contraindicated. Even category D drugs are contraindicated, but some are still, we find that many are still being used because the benefit outweighs the risk. I'll put out in a simple fashion and some commonly used drugs in pregnancy and their categories. For example, analgesics and antipyretics, most of them fall under category B and C. Paracetamol, the popular paracetamol, is a category B drug. It's not a category A drug, but we use it. Aspirin also is a category C drug, and there may be indications for the use of aspirin in pregnancy. Antiemetics mostly are also category B and C drugs. So in using them, we know that there are no evidence of fetal risk in animal studies, and we extrapolate that and use them for pregnant women. Antihelmintic agents are category B drugs. Almost all anti-malarial drugs, antifungal drugs are category C drugs. And then drugs used for the treatment of tuberculosis, that's Koch's disease, either fall in either category B or category C drugs. And then we now have the vitamin B, vitamin C, vitamin D, vitamin E, and folic acid are all category A drugs. So we can see that most drugs will not fall under category A drugs because of the difficulty in carrying out proper studies, well-controlled studies on them. Of course, thyroxine use also is a category A drugs. Then we find androgens, estrogens, norethine, dronestrels. They are all category X drugs that cannot be used in pregnancy. Okay, so another slide there is showing this also. And most antibiotics fall under the category B and C, and some are in category D. For example, the aminoglycosides, such as the gentamicins, they are category D drugs and will not want to prescribe their use in pregnancy. Fluoroquinolones are category C drugs. And then we have antiviral agents. Most retroviral drugs are either used for HIV/AIDS are either in category C or category D. But we know that the benefits outweighs the risk, hence the use. So we find that we have to prescribe them in spite of the risk, but they are in category C or D drugs. The acyclovir is a category B drug. Then hypoglycemic agents are mostly category B drugs. Antifungal agents are category D drugs. Okay, so we move on to talk about the psychotropic drugs. These are drugs that affect an individual's mental state. They could be legally acquired or illegally acquired. The legally acquired ones are strictly prescription-only drugs. They are not supposed to be bought over the counter in proper societies. Though we find that many of these drugs have been given out through the back door. For example, there was the scandal of tramadol use. You find that many people are consuming tramadol. They didn't buy it in the pharmacy with a prescription. They just went there and just bought it on their own. So you find people using many drugs that are supposed to be prescription only are using it for their own recreational use. So many of the drugs in these categories include anxiolytic agents, antidepressants, antipsychotics, mood stabilizers, the stimulants, opioid anticonvulsants, and then, of course, recreational use. You have alcohol, cigarettes, caffeine, that's in coffee, cocaine, marijuana. Those ones are social drugs, but they are also categorized as psychotropic medications. There are women who are on prescribed psychotropic agents, such as the antipsychotic agents, alloperidol, clozapine or olanzapine, who need to use these drugs must be evaluated properly, and anyone that is found to be maybe in category X or category D, it can be reviewed to find the one with the least harmful effects to be prescribed. For example, a drug like phenytoin and carbamazepine, they are both in category D, but you find that carbamazepine will be prescribed over phenytoin because the side effect profile of carbamazepine is less than that of phenytoin. So anticonvulsants, agents, antidepressants, many will have to continue using this drug in pregnancy. So the prescription has to be guided because of the potential harmful effects to the fetus, to the mother, and that pregnancy. I want to now touch on substance abuse in pregnancy. It's a gray area in clinical practice, and because many women who are abusing drugs do not seek for help, either because they are ashamed of their habits, or some don't see anything wrong with that or with their practice, or they are so lost. Probably they are already addicts to it, and they they cannot distinguish between reality anymore. So they don't seek for help. They've been consumed by the habits. So the signs and symptoms of it are subtle and you generally will not see anybody and quickly know that this person is abusing substances. And unfortunately, in the routine antenatal clinics, we do not regularly screen, or we do not screen for substance abuse when women present for booking or for antenatal care. You usually find that people seek for medical attention when there's already complications, such as medical complications or mental illness sets in. That's when you actually now know that, oh, this person, Madam A, has actually been abusing substances for a while. There are various terminologies. I'll just quickly run through a few. The intoxication is a clinical issue where somebody who abuses substances develop reversible substance-specific behavior, and that's intoxication. Withdrawal is when there's unpleasant clinical side effects associated with sudden cessation of a particular substance. Then tolerance is the need to use an increasing amount of substance to achieve a desired effect. Addiction combines the need for increasing dose and features of withdrawal with lower doses or absence of a substance for a given period. So it means that somebody who's addicted needs increasing dose of that particular substance, for example, marijuana or cannabis, and there is the presence of withdrawal symptoms once the drug has not been given for a given period of time. So the person is constantly craving and seeking after that particular medication. And then you have dependence. Dependence also talks about the desire to take increasing amounts for an increased duration of time. A substance abuse dependent woman is already an addict. So the definition is almost interchangeable. So it's a maladaptive problem in the society, and you find that based on studies that have been done, you find up to 25% of pregnant women actually abuse substances. It's difficult to manage because of the pregnant state. So the categories of drugs abused are the CNS depressants, such as alcohol, anxiolytics, hypnotics, the opioids, such as opium, tramadol, codeine, stimulants, such as cannabis and cocaine, hallucinogens, and psychomimetics, such as LSD and phencyclidines. So these are the categories of substances that are abused. We have them both in the resource-rich nations and also in the resource-poor countries. And the effect of substance abuse can be on the mother, the fetus, on the course of that pregnancy, the newborn, and even the developing child. Is the chart just to summarize the effect of substance abuse in mothers. You find that medical complications can set in, hypertension can set in, hypotension can set in, hyperglycemia, hypoglycemia, they could be malnourished. These people are prone to sharing infected needles, could develop blood-borne diseases, could develop HIV/AIDS from these problems. They could actually have psychosis and develop schizophrenia. They are also predisposed to violence and sexual assault while pregnant. The fetus and the pregnancy, congenital anomalies abound for many of these of women who are pregnant with and are abusing substances. Spontaneous miscarriages can occur. Antepartum hemorrhage, placenta previa and abortion placentae can occur. Intrauterine growth restriction, premature rupture of membrane, low birth weight babies can be born, and then of course preterm labor can occur. In the newborn after birth, fetal alcohol syndrome is one of the more publicized complications of excessive use of alcohol while pregnant. Withdrawal symptoms can occur in the baby after birth when substances have been abused for a while. Respiratory depression can occur from prolonged use of opioid analgesics and opiates. Irritability, tremors, even sudden infant death syndrome can occur. And then in the developing child, of course, learning abilities, disabilities occur. Autonomic nervous system dysfunction can also occur in this in the children born to women who abuse substance. So how do you manage? You need to evaluate the woman, and it's a multidisciplinary approach. The obstetrician cannot handle it alone. The psychiatrist cannot handle it alone. The clinical psychologist also cannot handle it alone. So the history must be obtained, and the ability to get good history depends on how much confidence you're able to gain, how much confidence and trust the woman has in that physician. So one must be careful, with the help actually of a psychiatrist or clinical psychologist, to get the history as appropriately as possible. And then if the woman is unable to provide adequate history, maybe the caregivers can help with the history. Physical examination as appropriate, including mental state examination also is important. And then the investigations would include toxicology screening, where urine samples can be analyzed, the hair samples and blood samples can be analyzed, in addition to the general examination investigations that will be done for the woman, such as electrolyte screening, the liver function test, and the complete full blood count for the woman. So the principles of management of women who have been exposed to substance abuse is, you must keep in mind that it's a multidisciplinary approach. Proper social support is important, because even after treating the woman properly medically, she may relapse if there is no proper social support. The treatment of the medical problems that have been found in her, also the mental health issues should be addressed. Then abstinence from substance abuse. Then, of course, because she's pregnant, proper antenatal care and supervised delivery. And thereafter, rehabilitation is important. And in addition to social support, if she has no job, it would be good if she's trained to develop a skill that can help her. And of course, follow up to ensure that she does not relapse. So the abnormalities with some of these medications have been put here on the chart. We mentioned phocomelia, which is in association with thalidomide. In tetracyclines, you could have tooth discoloration, bone and enamel dysplasia. Aspirin can cause craniofacial anomalies, pulmonary hypertension, and premature closure of the ductus arteriosus while in utero. Then phenytoin causes craniofacial and limb abnormalities. Carbamazepine is associated with some CNS malformations. Chloramphenicol causes great baby syndrome. And we also have warfarin causing chondroplasia punctata, nasal hypoplasia, bilateral optic atrophy. And methotrexate also involved in formation of craniofacial malformations and malformations of the extremities. Cocaine can cause placental abruptio, urogenital defects, dysmorphia, neurobehavioral problems, and vasculopathies. Of course, alcohol can cause fetal alcohol syndromes and growth retardation. Interestingly, no teratogenic effect has been documented with marijuana use, but it has been associated with meconium stain liquor and the precipitate labor. All right, so the general principles of drug prescription is that prescribing medications for pregnant women is a balancing act, because there are no risk-free alternative. There's always a risk, even those with category A. And women with chronic illness such as diabetes mellitus, seizure disorders, psychiatric disorders, who will require medication throughout pregnancy, one must be careful to select the safest class and the safest drug in that class for such women. So the general principles in prescribing drug is that as much as possible, one should exhaust the non-drug treatment options. And then drug prescription should be individualized. Every woman should be taken care of as a special patient, and it should be individualized. The prescription for Mrs. A may not necessarily be a prescription for Mrs. B. So one should individualize it. And the maximal benefits must be sought against minimal side effects. We should choose the best drug with the best safety record over time. And one must be cautious with over-the-counter drugs. One must be cautious with new drugs. And one must also be abreast with the latest information on every drug that is available. Some drugs have been prescribed for several years only to be discovered that they actually have some side effects which may be untoward in pregnancy. Okay, so we should also prescribe for the shortest possible duration, and medical records should always be reviewed anytime the woman presents in the antenatal clinic. So we'll conclude by saying that because of the unique nature of pregnancy, clinicians must responsibly counsel and guide participants on the safest therapeutic options that are available, and also help women who have been exposed to potentially harmful substances and drugs in order to minimize the risk or the side effects and achieve the best fetal-maternal outcome. These are my references. Thank you for listening.